Hello, and thank you for joining us today for our first webinar for the Survivorship Champions program. We are really grateful that you joined us today to learn more about what we hear from cancer survivors about what they need. We started launched the Survivorship Champions program this year as a way to really share what we hear from cancer survivors with the clinicians and researchers who take care of them and try to help improve survivorship care. And I'm really grateful to Veronica Peniotu, who's our advocacy and programs manager, for helping shepherd this program, and also to our guest today, Darcy Burbidge, who has helped us put together resources and materials for the Survivorship Champions program. She's a leader in oncology nursing, and we're really grateful to partner with her. And Darcy, I'd love to just give you a chance to say a few words before we get into the survey results.
Oh, thank you, Shelley, and thank you for inviting me to join you today. And, I just want to applaud the efforts of the National Coalition for Cancer Survivorship for, taking on this survey year after year, especially to help us as clinicians inform the care that we provide to our patients, and also the survey participants, because, their voice is critical in order for us to improve the care that we provide to them. So I'm really looking forward to presenting alongside of you today to share the results with those on the call.
Thank you, Darcy. We shared these results earlier this year, but we've tailored this presentation to what might be helpful to clinicians and researchers who care about survivorship. And so Darcy helped us kind of hone the slides to the most important information, and there are some areas where she's going to chime in with comments from her perspective as a clinician. So I'm going to go ahead and share my slides, and we'll get started talking about the survey. There we go. So this year, 2021, was the third year that we did our State of Survivorship survey. And it's something that we really love to be able to do. And it's become such a really important part of our program because we get incredibly important and relevant data from cancer survivors across the country. So our goals this year were to continue to delve into the cancer patient and survivor journey from a range of perspectives, and really use this data to help us better understand how we can support cancer survivors in our mission to advocate for quality cancer for all cancer survivors. As we go through the survey, anything you see in blue and red means it was statistically significantly higher or lower by audience, and then we also indicated where there were some changes from our 2020 survey. We try to ask some questions that are similar from year to year, or that are the same from year to year, so we can see if there are any trends, but then also delve into different areas each year based on topic areas of importance and also what's going on at the time. So we asked quite a few questions this year about telehealth and about COVID-19, and we're not going to go into detail on those in today's webinar, but you can find all of that information on our website, where we have the full report and some infographics and some other materials that describe the results of the survey. So today we're going to talk about four areas that we delved into in our survey: disparities in care, the cost of cancer treatment during COVID, and the meaning of survivorship. So disparities in quality of care is really important. Actually, before I get into this, I want to just say one thing that's really important about the survey. We recruit a national sample that is representative of cancer survivors across the country. So the first year we did the survey, we recruited participants and we enlisted some of our fellow cancer advocacy organizations to recruit participants. So that we had a good sample, but they were all people who had some connection to an advocacy organization. And we looked at the demographics of the people who responded, and it wasn't sufficiently representative of cancer survivors in the country. So in the second and third years of the survey, we changed how we recruited, and we recruit from a national sample. We have quotas to make sure that we have the right mix of different types of cancer, ages, race, ethnicity, income levels. We wanted to make sure that we had 50% who are Medicare eligible, because that's who has cancer in this country. So it's a really good sample, and we also continue to ask the people who are connected to NCCS. So you'll see in a few places where we talk about the difference between the national sample and the NCCS connected. When we ask them questions about the symptoms and side effects and some of the aspects of their cancer experience, they're very similar, but we do see some important differences in decision making about care and in satisfaction with their care. The NCCS connected patients have a little bit higher expectations and therefore a little bit lower satisfaction with their care than what we see in the national sample. But across many of the areas, they're very similar, but you'll see some places where we note those differences. But I do think that having that nationally representative sample is very important to make sure that we are capturing a good sample of that represents cancer survivors in this country.
Mhm.
So most cancer patients naturally describe their treatment and care as excellent. And we do, before we do the survey, we actually do these in-depth interviews, and that really helps us frame the questions. And so the quote, "I'm alive, period," was from one of those in-depth interviews. The number one reason that we hear from survivors as why they describe their care as excellent is because they're alive. And sometimes this is even after they're listening to them describe care in their interviews that doesn't sound like excellent care. That sounds like a lot of burden on them to get the right diagnosis or to navigate and coordinate care among different providers. But then you say, well, how would you rate your care on a scale of 1 to 5? And they say 5 because they're so grateful for the people who saved their life. And so that's why we see, 75% of the patients in the survey said their care was excellent. Where you can see the NCCS connected, only 51%. This was where I was talking about a little bit of difference in expectation levels and how they rate their care. But importantly, you can see differences in groups that were much lower in their rating of their cancer care. Young adults, Black, Hispanic, and Latino respondents, patients who were on chemotherapy or immunotherapy, targeted their drug therapy compared with patients who had surgery only. We asked questions about their support systems from their family and from their healthcare team. And the ones who said that their support systems were excellent were much more likely to say they had excellent care than the patients who said that their support systems were just fair. Also, how well informed they felt about their side effects was correlated with how they said how well they rated the quality of their cancer care. And then also, we do see this survey includes people who are in treatment now, recently diagnosed, to people who are many years out. And as people get further out from their treatment, their rating of their care goes up. I think they maybe forget some of the bad things or the challenges that they experience in their care, and again have that grateful to be alive focus that they want to rate their care team highly. So we do find out that we did see that few patients are informed about or participating in clinical trials. So we asked, at any point, did you participate in a clinical trial? And 9% say they report participating. And then did your healthcare team offer or discuss a clinical trial with you? 11% said they did. Now, this was higher in younger, Hispanic, Latino, urban, higher socioeconomic. We did ask also where they were treated, at academic medical centers or in the community. We also followed up with asking them specifically where they were treated, and then we went through and kind of correlated that. And a lot of people don't know the difference necessarily between an academic center and a community cancer center or a community being treated in the community. So sometimes how they reported their care wasn't exactly right based on where they told us their care was, and that makes sense. I don't think that's something that cancer patients think about, that to know whether the hospital they're going to is considered an academic medical center. But we did try to look at where there are any differences. So Darcy, I know you had some thoughts on this you wanted to share.
Right. Thank you, Shelley. Yeah. Unfortunately, I wasn't surprised when I saw the results of this because it's consistent to what we see in the literature as clinicians, that there's consistency, low participation in clinical trials. And, we do hear from our patients that they're not being offered clinical trials, or if they are being offered, they're not given the reasons why they are perhaps not eligible for the clinical trials. And I do know that, advocacy organizations, in addition to NCCS, some of the other patient advocacy organizations, Tiger Lily Foundation, National Breast Cancer Organizations, et cetera, along with professional organizations such as, Oncology Nursing Society and ASCO, and as well as, the individual health systems in which we practice, are all looking at this and finding or trying to find out ways in which we can do better. And I know that some organizations are also putting together, clinical trial ambassadors that can go out into the community based on the fact that they may have participated, and just trying to talk to the community to help build a sense of trust in regards to helping them want to participate or even ask the questions of their providers, so we can increase the numbers, because this is the only way that we're really going to improve our overall survival rates and also quality of life, is to participate in clinical trials. So look at these new medications and find out how effective they are in treating individuals. There's also some other innovations that they're looking at, with telehealth and COVID, especially in regards to perhaps the clinical trial participation regarding the relaxing the requirements, in the sense that can we have more open access with clinical trials, because sometimes you find a clinical trial you may be eligible and are eligible for, but it may be in another part of the country, or your health system doesn't participate in that. So there's a lot of things that we can do better, and I think a lot of people are looking at that now. So thank you.
Thanks, Darcy. There was a question of whether the participation was higher for people in academic medical centers, and yes, and I don't know the exact number, but I do know it was higher for people treated at academic medical centers, which makes a lot of sense. But I think, this low number of where the healthcare team offered or discussed a clinical trial with you is really critical, because there's a lot of effort to try to improve diversity in clinical trials and recruit more people. But to me, and I think there's a lot of data out there that shows it, that the most important factor is whether your clinician recommends it and discusses it with you. And I attended ASCO's Quality Symposium in September, and there was data presented saying there's not a lot of difference in how people, in the rates at which people respond to that if offered. So we just have to make sure that we're offering it to everyone, and offering it, and not having differences in rates at which people are offered it based on, any income or demographic factor. That's just, to me, there's a lot of things we can do to decrease barriers, but the biggest one is whether or not patients are offered the trial. So we also asked about which providers a patient saw during their treatment and how helpful each were. And so the oncologists and surgeons were popular and got the highest ratings. So the bottom bar is whether they saw that type of practitioner, and then the top line is if they rated them as very helpful. So if they saw a primary care physician and said that they were very helpful, then that would be in that 68% line. So there was, you can see that there's a lot of, not as many patients saw clinical care coordinators, social workers, hematologists, patient navigators, and nutritionists and dietitians, but then also their level of satisfaction with some of these was lower. And Darcy, I know you had some comments about this as well.
Yeah, thank you, Shelley. When I first saw the results of this, I was initially a little surprised to this question. However, upon further reflection about my own practice and what I hear from the patients that I care for, was, perhaps the support services aren't as well represented. For example, we could probably have twice as many social workers and really not be able to meet the needs of everyone who could benefit from meeting with a social worker, even if it's for, financial assistance, or if it's for counseling. And also, dietitians. I know where I practiced, there was one dietitian for 2,000 newly diagnosed patients, plus everyone else who was living with and beyond. And there's no way one person can see everyone who's diagnosed with cancer that really needs their services. And then on top of that, you have insurance reimbursement. So if insurance is not going to pay for someone to see a dietitian, although we're telling people eat healthy, but and they're not quite sure how to get started. But if there's an individual who is diagnosed with a GI or head and neck cancer where they really could benefit from seeing a dietitian, those are the ones that are getting in to see them a little bit more frequently. And the other thought I had was, there's so many things that patients need. And I don't mean that in a derogatory way. I just mean it in the sense that, there's so many resources that are lacking. for financial resources. Even if you have insurance, living expenses are getting higher. So there's just so many resources that are needed by individuals living with cancer, and not just them, but if it's their caregiver support, or there's so much that can be done better. And a lot of the support services aren't reimbursed. I hate to keep saying that, but then that kind of drives the bottom line for health systems. So if you're not bringing in income, you're not, we don't have enough support to offer that, which I think is desperately needed by our patients, not just those that are in treatment, but those that are living beyond treatment, living with metastatic disease as well. So, there's just so many factors that come into this. And I think we can do a lot better as a health system. And I think this is a really important slide to take back to your leaders and managers to say, here is something that the patients are saying they didn't find this helpful. Why is that? Maybe to your own individual patient advisory council, and really get into the what can we do better. I suspect there's much that we can do better, but this really struck me as something that we can improve upon very readily.
Right. And also, when we get to the concerns that patients have where they don't feel like they're being addressed, these are the providers who could help them with that. And they're not seeing them because, like you said, a dietitian or nutritionist may have, 2,000 cancer patients and not be able to see everyone. There was a question about whether we asked about rehabilitation providers and physical therapy, occupational therapy. Yes, we did. This slide is just the top 10 in terms of the responses as to whether a patient saw this provider. So I don't have the numbers specifically as to how many saw them, but obviously it was less than 10%. But if you want to email us, we can get you that information and how they rated them. But this slide was really just the top 10 types of providers that people saw.
And just one more thing, Shelley, I think that was a really great point that was raised by one of the participants, because prehabilitation, rehabilitation are really important to help patients get their functional status improved even before treatment starts, or during treatment and after treatment. So maybe it's not the top 10, but maybe that's just something else that that could be improved upon in the continuum.
Right. Well, and I think it goes to the fact that patients don't know that it's available to them,
Right.
and that's why so few have seen them. And we are actually working on some resources right now to help patients learn more about why rehabilitation is an option for them and how they can try to request those services, because it could be so helpful for their functional status.
Absolutely.
So most of the respondents gave high scores on coordination of care. And this is something we've heard in previous surveys. And so this year, in addition to asking, was your care coordinated well, we asked the question of, did you have to share information from one healthcare provider to another? And more than half said yes, they did need to, even though 93% said that their care was well coordinated. I know that whether the patient has the burden of sharing information is not the only measure of care coordination, but to me, if you are the one responsible with sharing information between providers, that is not as well coordinated of care as we would like to see for patients. It's a burden to add to patients' plate while they're going through cancer treatment, to be the one that's sharing information from their different providers. So this kind of goes to, what I talked about earlier, that they want to, and they have such gratitude to their healthcare team that they rate them highly. But then when you dig a little deeper and ask a different question, the care coordination is not there. And that is, I don't think, surprising, because we know that there's a lot of data, challenges in sharing information. But what ends up happening is that's a higher burden for cancer survivors to have to take on to do that themselves. And so I think we will continue to delve into some of these questions when we ask about their perception of quality, to kind of dig a little deeper in our survey next year, which we are planning and looking forward to continuing this survey every year.
And that's a great point, because, that's, as you said, one more thing. And, with EHRs, you would think that they would be interfacing a little bit better in this, technology world that we're all living in.
Yes.
But obviously not, or not yet.
Right. So then we also asked about whether they felt like their healthcare providers were approachable and respectful. And the majority said yes. They felt like they could talk to their healthcare providers about their concerns, and they felt their providers respected their questions and concerns. You can see here that this is where the NCCS connected patients are a little bit more, discerning and lower satisfaction levels. And there were also differences by age, with our younger patients saying, less likely to feel that their team was approachable or that they were respected. Some, some said that they felt like their providers were projecting their biases onto me, one of the Hispanic respondents. And then also some of the women respondents said that they felt more dismissed, or they were had a lower response to the question about feeling like their questions and concerns were respected.
Yeah.
So we asked about a number of side effects. Physical. This particular slide is talking about some of the physical side effects, and so feeling overly tired is at the top of the list, and that is consistent with our surveys over the last 3 years. And then you can see, but the top 10 symptoms that patients reported, and then also the levels, the numbers in blue are statistically significantly higher. So on sexual concerns, it was 28%, but for men, it was higher, 38%. But you can see a couple of these columns where women had higher levels of concerns, or had higher reported experiencing these symptoms more frequently. Young adults also more frequently. Hispanic and Latino respondents, many of them were more frequent. And then the low income respondents also were more likely to report these side effects. And these are the physical side effects. Then we also asked later in the survey, you'll see about some of the other concerns that they had that weren't just physical.
And I think it's also important, Shelley, the number 3, where it talks about depression, anxiety, and
Yeah.
mental health issues. Emotional support is, critical to individuals diagnosed with cancer and their caregivers throughout the continuum of care. And um, I suspect and know that some of these can, have overlapping side effects when it, impacts fatigue, also, aches and pains. So, there's a lot of symptom clusters that can occur in our patients. So if you have one symptom, more than likely you may have others as well. And, that's another avenue for an improvement. There's definitely not enough health psychologists to help all of our individuals that
Mhm.
could benefit from specific support for their feelings that they're experiencing with the depression and anxiety, and it's not always medication. Sometimes you need both the
Right.
behavior therapy as well as medication, just to help you get over that initial, and then the more talk therapy, even if it's individual or group support, it can be very helpful as well. And that's why I think the work that you do with NCCS, and why the individuals who are part of NCCS have a lot more they know that things can be a lot better based on what they're hearing from others that participate.
Right. And then when we get to, we asked how helpful were your healthcare providers in addressing these, and some of these, I think that, well, we'll see in a future slide, but the mental health issues were much less likely to, patients were much less likely to say they felt like they got the help that they needed. But I just want to point out how striking it is that more than half of the young adult survivors had depression, anxiety, and mental health issues, compared with 27% in the total population. So that's something really important. I mean, obviously, across most of these measures, the young adults were more likely to report experiencing these symptoms, but that one was very high. Um, and not surprisingly, patients with metastatic or advanced disease are more likely to experience almost all of the major symptoms. And this was comparing the total number versus the lighter bar is the percentage of patients with metastatic disease that reported experiencing these symptoms. We also, measured by completed treatment or still in treatment. So while 2/3 said they felt informed about side effects, in most cases, less than half believe their healthcare provider was very helpful in addressing them. So again, here we have these were the top 12 out of the 19 symptoms we asked about. And then we said, was your healthcare team helpful, very helpful in addressing them? So you see much higher numbers in terms of how helpful the healthcare team is in things like nausea and vomiting, skin irritation and rash, dermatologic problems, and even in weight loss. But then looking at, some of the very top concerns of the fatigue, sexual concerns, and depression and anxiety, less than half or far less than half felt like their team was very helpful in addressing them.
Right. And that goes back to, what we were just saying in the prior slides, Shelley, was that um, some of these symptoms, especially if they can be managed with, a pharmaceutical agent or, um, another remedy, such as, creams, etc., for dermatologic issues, it's um, easy, quote unquote, to provide that prescription for our patients. However, most of the concerns and side effects that they're having really going to take some time that the clinician sits down and listens to them and finds out, how often this occurs, really assesses where they are, what they've tried, and work with the patient to help them overcome some of these side effects, and refer them to, if it's um, physical therapy, occupational therapy, other types of rehab services, acupuncture. A lot of integrative therapies have been found to be helpful, though there's not a lot of randomized controlled trials, but we know anecdotally from our patients that they're helpful to patients. So those things are very important as well. So I think it takes time for the clinician to do this, or the care coordinator, which we know
Right.
that there needs to be more of that as well.
Yeah. And I just want to point out at the bottom, it shows the note that the scores went up on many of these items this year in terms of how helpful the healthcare team is. So that's positive because we did see bigger gaps in our survey last year for some of these items. So then we asked about how for patients who are post-treatment, how did they describe their post-treatment care? And the percentage who described their post-treatment care as excellent is 12 points lower than how they rate their cancer treatment. So still 63% said it's excellent, but definitely not as high as the people when we asked about the cancer treatment itself. And then we asked, what kinds of topics are you talking about with your healthcare team in these post-treatment visits? And so the quality of life, exercise and nutrition, physical function, mental and emotional impact is much lower in terms, only 25% are talking about that in these post-treatment appointments.
Also, I was curious to know, and if perhaps this was part of the mental and emotional impact of illness. It's not called out per se as fear of recurrence. So I think fear of recurrence is a huge concern for our patients living with cancer. In treatment, after treatment, especially when you kind of graduate from the active treatment to maintenance therapy, where you can lengthen the time of visit. It's not uncommon to have the aches and pains that, oh, is this really an ache and pain, or is this my cancer returning? So I'm sure that that's all part of the mental and emotional impact of illness as well, that we need to do a much more better job of helping to normalize that conversation as to, it's not uncommon to have these feelings. These are some things that you can do. So even if patients aren't bringing it up per se, but us as the clinician, we need to bring that information up as well.
Great, thank you, Darcy. Sorry, it was taking me a minute to advance the slide. So in addition to poor outcomes, several themes emerged among those who felt like they had just good, fair, or poor care. So one was income disparities, and these are quotes from the in-depth interviews we did, someone said, to be honest, I'm poor. I just went with the program, tried not to bother anyone. And then the lack of support and coordination of care. Someone said they had no continuity, see a different infusion nurse every time, a different NP every time. We discuss medication or scans and they never get ordered. Insurance companies and doctors' offices don't communicate. No one seems to know me. And then another theme of not having options or a voice in their care. I do not feel like I was even consulted about options because I was young and considered not smart enough to be in charge of my own care. I feel like when I finished treatment, I was just dumped. There was very little care given to how I would have a lifetime of survivorship ahead of me. No one even wanted to hear about complications I was having, even though some ended up being early signs of poor lifelong outcomes. So all of those are a little bit heartbreaking to hear, but these were some of the things we heard from people who had just, that rated their care more like just fair or poor. Okay, so now we're going to talk about some of what we heard from patients in terms of the costs of care. And we really looked at this broadly, not just financial costs, but some of the other concerns that they deal with. So we kind of grouped them into three categories: the physical health concerns, emotional and lifestyle concerns, and then financial and insurance concerns. We asked about a range of these concerns. These are the percentage who said that it was a concern for them. The same issues rose to the top in our survey last year. On the physical side, maintaining a healthy weight is very high and continues to be. And then just thinking back to our previous discussion about access to or support from dietitian or nutritionist, I mean, it's really a big concern for patients to maintain a healthy weight, but they're not necessarily getting that support. And also the third one, getting enough exercise, and then managing side effects, maintaining a proper diet. In terms of emotional lifestyle, uncertainty about the future, being there for family and friends, emotional support, mental health support, maintaining relationships, family and caregiver support, and then feeling isolated and lonely. And then on the financial side, the cost of medical care, the cost of prescriptions, financial support, understanding insurance, non-medical expenses, and then getting and keeping insurance. So, sorry, I have to move this to, oh, I'm sorry, to go back. I have my slides. Okay, great. Sorry, I was blocking the bottom of my screen, so I couldn't see the difference between the two bars. So this is similarly the three categories of top concerns, and the dark blue bar is the national sample, and then the lighter blue bar is patients living with metastatic cancer. And so you can see that across every range of these, that was much higher levels of concern for the patients with metastatic disease. And particularly, I mean, all of them, but then obviously the financial implications of dealing with metastatic cancer are incredibly important and long-term, because you will be in treatment for the rest of your life. And so the cost of care, having financial support, and the cost of prescriptions and treatment is very high.
And in looking at this and in light of the health disparities that we were talking about a little bit beforehand, getting enough exercise, maintaining a proper diet. If individuals live where there's food deserts or there's not access to fresh fruits and vegetables, that's going to be a little bit more challenging. And also the cost, as we talk about financial cost of care, but just the living expenses, as we also mentioned, and also enough exercise. And if you're telling our patients, just go outside and walk, but if their environment is not safe, or if there's not street lights, or if you don't have sidewalks and you have neuropathy, that's going to be a little bit challenging just to get that exercise that we think, oh, just walk. And, living through the pandemic's a little bit more challenging as well, because if people were mall walkers, they're probably not doing that as they used to. Also, when we talk about the financial cost of care, we see this a lot with some of the oral oncolytics that patients are on because they're so expensive. Sometimes patients are, taking half their doses just to spread it out so they have have more of the medication. But we know that if they're not taking the proper dose, there's a potential that it's going to decrease their overall survival, also reduce their quality of life as well. So, once again, it just comes down to, getting to know our patients, listening to where they are, and getting them to the right resources to help them to where they need to be, and also paying attention to the individuals living with metastatic disease. And I really appreciate this year's survey, Shelley, where you really took that into consideration with individuals living with metastatic disease, because they are increasing. So we really need to address
Right.
them in our survivorship programs.
Yes, we do. And we hear that a lot from our advocates who are living with metastatic cancer. And we um, we did a focus group with some staff at NCI so that they could really hear directly from people living with metastatic cancer and what some of their needs are in terms of survivorship research and survivorship programs. And we do hear from people living with metastatic cancer that they're excluded from a lot of the survivorship programs at their hospital or cancer center because they're not post-treatment survivors, but they have the same needs. They have higher needs, and a lot of the needs that they have are the same kinds of needs that people who are post-treatment have in terms of the kinds of support, managing their diet, getting exercise, things like that. But they're not included in those programs because um, they have not completed treatment, and I think that's just a huge problem that we need to address. We shouldn't exclude people. The survivorship concerns are really about quality of life living with cancer, whether you're in treatment or not. And we shouldn't be excluding people because they have not or will not complete their treatment, that they will stay in treatment because they have even higher needs. So, sorry, let me switch to the next slide. Again, this is another slide showing the same thing about concerns being higher for patients living with metastatic cancer. And I think you can see that here in addition to on the previous slide. So we asked about what kinds of financial sacrifices patients had to make as a result of their cancer. And so we asked a range of different types of things that they might have experienced, whether it was spending their savings, applying for government assistance, delaying a life event, uh, all the way down to at the low end, not as many, but still, it's unfortunately becoming an important trend in how people fund their cancer treatment is starting a GoFundMe or some kind of campaign to help with expenses. But 40% experienced at least one of these. But then if you look at these different groups, women, young adults, Hispanic Latinos, low income patients, people with metastatic cancer, and people still in treatment, were much more likely to have experienced any of these. And if you look at the young adults, 84% experienced one or more of these, compared to only 40% in the national sample. I mean, I don't mean to say only 40% because that's still, almost half of cancer patients experiencing these, but it's double that percentage for the young adults. But you can see how much higher the levels are for some of these groups in terms of experiencing some of these financial sacrifices as a result of their cancer.
And not only for them, but perhaps for their family members as well.
Right.
If they are a young parent and have children that they perhaps want to send to a special school that they maybe not be able to afford, or college tuition out of state. So, it really has an impact not just only on the individual with cancer, but that down effect on the whole family and caregiver unit as well. And, bankruptcy, we know, is high among individuals that have cancer, and that's going to impact your credit. When you come out of your diagnosis, and how to apply even for credit cards and different things like that. So it's very very impactful.
Yeah. And then we also asked about the impact of their cancer diagnosis on their work status or work environment, whether they've missed work, worked fewer hours, taken a leave of absence, felt like their work suffered, et cetera, down to including quitting their job or being let go or fired. Um, at least 43% experienced at least one of these items below, higher for the NCCS connected patients, but also again, the same groups having, a much higher percentage of experiencing some of these impacts to their work. This is why also we've been advocating very strongly for paid leave as part of the current negotiations happening in Congress, because we hear from cancer patients that they've had to miss so much work, or even for their caregivers missing work to take care of them, and not having that paid leave. They can have unpaid leave, but it doesn't help them as much as paid leave would, and especially people with lower incomes can't take unpaid leave. So I think this is really important, and again, these same groups feeling much higher effects of these concerns.
Right. And also, too, when we talk about job lock as well, individuals are afraid to leave their position in case they can't find a job, or if they'll find out that they have a history of cancer, and maybe that would be impacting on another position that they're very qualified for. So those are some other things that we also hear about too. That is probably all rolled up into what we're hearing from our patients.
Yeah. Okay, so treatment and post-treatment during COVID-19. So it did not, the COVID-19 pandemic did not have a huge impact on patients' perceptions of the quality of their care. I think this is very good news. I know that, we are deeply grateful to all the healthcare providers out there who made sure that patients could continue their cancer treatment during this pandemic. I know it's been incredibly hard for everyone, and that there, a lot of changes in how care was delivered had to happen. But from the patient perspective, they were still pleased. They said their care either stayed the same or was better, and only 4% said their care was worse than before the pandemic. We didn't. We saw that patients didn't necessarily always know that their treatment was different from how it might have been before the pandemic, and I personally think that's okay. I think that's great if they're sort of insulated from that. They're getting the care that they need. They're pleased with it. They don't necessarily know how much things might have changed because of all the hoops that had to, that the care team went through to change how to deliver care to make sure that it was still safe for both healthcare providers and cancer patients. So that's, I think, is good news, that it didn't have a huge perception on a huge impact on perceptions of quality care. We asked about use of telehealth, and 40% had some appointments via telehealth, higher for certain groups, whether the NCCS connected, people living with metastatic cancer, people who were receiving palliative care or treated at a private cancer center. So we asked about the types of appointments that they had, and how highly they rated those appointments. And the majority said that they were excellent or very good on most types of appointments, with a few exceptions, or the lowest rated ones being the first visit with a healthcare provider. That's not the preferred way to meet a new healthcare provider. Getting a second opinion, it's an important option for patients, but it's not ideal to do that via telehealth. And then physical therapy or rehabilitation just was not seen these numbers were lower because fewer people had telehealth appointments for them, but it wasn't seen as effective, which makes a lot of sense. It's harder to see the kind of, what you need in physical therapy if you're not in person to do that. We also asked about, going forward, would you prefer in-person or telehealth for a range of types of visits? And overwhelmingly, people prefer in-person. I think that, telehealth is still an important option for people, and there were a few types of visits where they said that telehealth was preferred. But I think about the burden on a cancer patient going through treatment, of how many different types of visits they have to have. And while they still prefer to be in person for most of them, there are some that can be handled by telehealth. I want to make sure that it's still an option for patients if it would help them, if they live far from their cancer center or where they're receiving treatment, if they're, trying to juggle treatment and work and family, if having some appointments like counseling and education or medication management or mental health services, that having the option to have them by telehealth could help make their lives easier while they're going through cancer treatment.
I agree, Shelley. And the other thing that I hope will hopefully continue or perhaps get more um, providers involved is that, I think it's important if we stagger the times too. I mean, not everybody works or can be available 8 to 4, what we consider like, the doctor's office hours. But, if we can early morning appointments, late afternoon or early evening appointments, I think is really going to be important as we move through and, further through the pandemic and hopefully post pandemic care. But as you said too, if there's transportation issues, if there's care issues, if we can pivot quickly to a telehealth visit if patients are running late and things like that, can we work with the patient so we can provide that patient-centered care and meet them where they are relatively easily for them rather than having to take time off work and wait for an appointment as such. So I think there's a lot of opportunity, and I hope, as you said, that this will continue as well.
There was a comment from one of the participants saying, in my experience, counseling definitely is a good fit for telehealth, especially while masks are still needed for in-person visits. I think that's really true. And I think that we have seen a lot of evidence that it's so if someone has to go to like a weekly visit for therapy, being able to do it by telehealth is so much more convenient. And I think that's one area where we've really seen positive impact in during the pandemic of being able to access. But yet still, patients still preferred it, but a not insignificant percentage said they would prefer telehealth for that. I think, that it just makes it more accessible to people, and there are more options where you can do it in the evenings or, things like that, like you said, Darcy, to be able to make it more accessible to patients. So the next group of questions that we want to talk about is the meaning of survivorship. So we asked about, is your focus on getting rid of the cancer no matter what, or maintaining quality of life as much as possible? And those undergoing treatment and living with metastatic disease are more likely to focus on maintaining quality of life, but they still lean heavily towards being cancer-free. And then you can also see this somewhat in the middle. So it's still, the focus is getting rid of the cancer. Not to say that the quality of life isn't important, it's just maybe not the top priority. But then again, if you're still in treatment or living with metastatic disease, those quality of life I guess your patients are more likely to say that quality of life is the higher focus than just getting rid of the cancer no matter what. And we asked about the term cancer survivor and whether you consider yourself a cancer survivor. And overwhelmingly, people said yes, they do. 85% of the national sample and 90% of NCCS connected. What I think is really striking is the comfort with the term increases over time. So people 10 years out were even more likely, or 10 or more years out, were even more likely to say they identified with the term. But 63% of those currently in treatment still believe that they are cancer survivors. I think that's wonderful, because I know that our founders 35 years ago, when they came together and formed the National Coalition for Cancer Survivorship, they really decided to define cancer survivorship from diagnosis. We know that not everybody loves that term, identifies with that term, feels like it describes their experience. And I think everyone should use whatever words makes the most sense to them as they're going through it. But the fact that, and this is again not the NCCS connected, but in the national sample, almost 2/3 of people in treatment still consider themselves a survivor, I think is just shows that what our founders set out to do is working. And I think, a lot of times we hear from people who don't like the word, and it can lead to an impression that many people don't like the word. And I think that, again, everyone should use whatever word feels right to them, but the vast majority of people do identify with the term, even those still in treatment or have recently diagnosed, and then it increases over time. And we asked, what other word would you prefer if you don't like cancer survivor? And so here you can see the word cloud with some of the words that people use: thriver, warrior, cancer patient. Um, this quote, it seems past tense, but I don't feel like I will ever be done with it. I manage it, live with it, keep getting tested, would rather use another word, but don't know what that is. Um, and then another who said, I like organizations that are not just about getting by, but about living your best life and emphasize living. And I think that's also why we like to say and try to always say it, and hopefully I didn't slip, is say people living with metastatic cancer, because that's what we hear from our advocates who are living with metastatic cancer, that that's how they like to be referred to, as opposed to a metastatic cancer patient, because they are living with it, and hopefully living, longer and longer with the advances in treatments. And so we try to respect that in what we hear from our advocates and use that language.
I know I've learned a lot from our patients over the years, and that's why I think it's so important, that the voice of the patient that um, continues to be heard and listened to as we inform our choices and programs as such, because that's why we're here. So we need to make sure that we're um, doing the best we can, and once we know better, we do better.
Right. Yeah. And then we asked, what does it be, a cancer survivor mean to you? And these were some of the different uh, quotes and perspectives that we heard from people. Um, feel like anyone is a survivor once they receive a cancer diagnosis. Um, anyway, I will let people read these, but I think these are nice expressions from people about how they view the word and in their own words. So we want to thank you for joining us, and also, for joining the Survivorship Champions program. We continue to work to develop materials and resources that can be useful, and so we would love your input on what can we create and what resources can we provide to clinicians and researchers who are interested in improving survivorship care. How can we partner with you? We have ideas, but we love your input and ideas. And I know, Darcy, I don't know if you have other thoughts you would like to share as we continue to evolve this program.
Sure. Thank you, Shelley, for presenting this, and, for those on the Zoom call today and those that couldn't join us. I think we all realize that there's not a one size fits all survivorship model, nor do all patients fit into the model that we have in our center. Some individuals could benefit from a multidisciplinary visit. Others may benefit from a, individual provider visit. It depends on the needs that they have, and their needs evolve over time. So we really need to assess them throughout the continuum, during treatment, after active treatment, or if they're on maintenance or living with metastatic disease. And I've also found most individuals don't want to come back to the cancer center unless they have to. Um, so if there is an opportunity to partner while they're there for another visit, and that goes back to coordinating care. So if you're coming for a follow-up visit and you need to see rehab, or if it's time to meet with a dietitian or a social worker, I think really it helps to have those programs and processes in place and really work with the individual patient to ensure that we're meeting their needs and stay in contact with our patients as well. What I tell patients is that, if you have any questions, feel free to give me a call, because there's so many providers involved in the care. And a lot of times I get a call, who do I call? The surgeon, the medical oncologist, the radiation oncologist, who do I call? And I say, why don't you give me a call and we'll figure it out together and we can help. So I think, just putting the patient, as always, at the center of our care, and ensuring that we're helping them where they are and meeting their needs is always going to be important. And also informing the disparities lens. I think this survey really highlighted that there is differences. We knew it, and here we see it again. So we really need to make sure that we are listening to our patients, and we're asking the right questions so we can help them get their the patients the care that they need throughout the continuum of care and in their communities as well. So I think it's really important, that we continue these conversations, that, the survivorship champions, I think is so important. And I'm so grateful that you all put this together, because I think it's really going to help all of us as clinicians, learn from each other, so we can provide the best care we can to our patients.
Thank you, Darcy. And your comments reminded me of a comment from one of the participants who said that the data supports the thesis that patients need their providers and payers to give them a whole person care capability. And I think that's absolutely right. And that is really a huge takeaway from the survey when you see the areas where patients feel like they have high need from the effects of their cancer and they're not being addressed, because we do end up not taking a whole person view of it. And I think that's really, really important, because, while your expertise may be in medical oncology, the fact is that the cancer has affected the person's entire life and not just the cancer cells in their body. And you're the person that they're turning to for help. And even though that may not be your expertise, we need to figure out how to get them the support they need for the other aspects of their life that have been affected by this cancer diagnosis and that cause them not to have the quality of life they would like to have.
Yes.
There was also a question from one of the participants about the using the word fighter, patients using the word fighter, and that there was some criticism when Senator John McCain was diagnosed. My view, I tend to shy away from battle terminology. I really don't like the expression that someone lost their battle with cancer. And I know people use that all the time, but I try to stay away from that because I think that it diminishes the experience that patients had, and they didn't lose a battle. They just, unfortunately had cancer that wasn't able to be cured. But I just, as far as if someone sometimes people are motivated by that themselves. And if they want to use that term, that they want to consider themselves a fighter, I think that's fine. I mean, I feel like when someone's going through a cancer experience, who are we to say what word they should or shouldn't use to really describe their experience? But I wouldn't assign it to anyone or use it uh, on someone. I would let them, define themselves that way. And I don't like thinking of it as losing a battle. Just like I hear patients say, they really hate the expression that the patient failed treatment. The patient did not fail treatment. The treatment failed the patient. And so it's a minor change in wording, but it's major from a patient perspective, because you feel like you didn't do something wrong. This treatment didn't work for you, and that's not your fault. And it's minor in how we say it, but I think people sometimes don't think about the implications of their words and how it affects the person living with cancer.
Right. Words matter.
Words matter. They absolutely do. I know that we shared in the chat the link to the survey report. There's an executive summary. There's written sections on each of the different areas that we delved into, including the ones we didn't talk about here. But you can find more about that on our website, and also some infographics. And you're welcome to share any of those infographics on social media that you would like, because I think that they, summarize some of the key points in a nice graphical way. So thank you so much for joining us today. Thank you, Darcy, for sharing your expertise, and to Veronica Peniotu and the rest of the NCCS team who helped us put this together. We look forward to continuing to work with all of you in the Survivorship Champions program and helping to meet your needs. So please let us know if there's anything that we can provide.
Thank you.
Thank you. Have a wonderful day, everyone.